Hi, it's Dr. Noni reviewing one of the most clinically interesting HIV presentations from AIDS 2026 in Rio de Janeiro. The headline sounds almost counterintuitive. Can a two-drug regimen maintain viral suppression when archived resistance mutations are already hiding inside proviral DNA? The regimen is doravirine plus islatravir, marketed as Idvynso. It combines doravirine, an NNRTI, with islatravir, a potent nucleoside reverse transcriptase translocation inhibitor. The FDA approved this once-daily tablet in April 2026 as a switch option for adults who are already virologically suppressed, have no history of treatment failure, and have no known resistance substitutions affecting doravirine. At AIDS 2026, investigators pooled data from 3 ongoing Phase 3 switch studies. They examined 1,143 participants who started doravirine islatravir on day 1, had baseline proviral DNA resistance results, and had virologic data through week 96. 300 participants had baseline NNRTI resistance-associated mutations. At week 96, 294 of those 300, or 98%, still had an HIV RNA below 50 copies per milliliter. Among 66 participants with archived M184I or M184V, 63 or 95% remained suppressed. And among 34 participants with both NNRTI mutations and M184I or V, 31 or 91% remained suppressed. The other 3 had discontinued by week 48. Importantly, a post-hoc review found that 2 had baseline doravirine resistance mutations that should have excluded them from the trials, while 1 developed treatment-emergent doravirine resistance. A delayed switch group produced similarly reassuring results. Every participant with an NNRTI mutation, M184I or V, or both, remained suppressed after switching at week 48. But we must interpret this correctly. This study does not prove that Idvynso can overcome established doravirine resistance, and it does not apply to patients with previous virologic failure. These were carefully selected patients who were already suppressed. There is also an important limitation involving proviral DNA testing. These assays can identify archived mutations when plasma RNA genotyping is impossible, but they can miss previous resistance. They may also detect mutations within defective viral genomes that are not driving active viral replication. Therefore, a mutation detected in proviral DNA may be clinically important, but it is not automatically equivalent to resistance within replication-competent virus. My take? These findings are reassuring for clinicians who discover an isolated, archived M184I or V, or selected historical NNRTI mutations in an otherwise suppressed patient. They suggest that we should not treat every proviral DNA mutation as an automatic veto against doravirine islatravir. However, the complete treatment history still matters. Before switching, review every previous genotype, every episode of viremia, adherence, drug interactions, and especially any evidence of doravirine resistance. This is promising durability data, but not permission to ignore resistance. The correct message is not that mutations do not matter. It is that the specific mutation, the reliability of the resistance history, and the patient's complete clinical context matter enormously.